substance use. It was mentioned again by our prior speaker. It's an issue that's not taken into account as often as it should be. We asked again, I think Alvaro gave this data, that 57% smoke presently, which is kind of amazing given the economics of smoking these days. And it is a primary predictor of almost every comorbidity that was mentioned today. If there should be smoking cessation dollars used somewhere, this is it. Here's the whole list of substance used, and you can see that the primary, once again mentioned, remains alcohol over the life course. I mentioned that before that the vast majority of this population is enrolled in a recovery process. And anyone knows anything about recovery knows these are life-changing behaviors. And I think that any clinician has to take them into account as they interact with him. Social networks. Social networks have become a buzzword these days because of the use of online services. And this work really comes from Marge Cantor, who I just mentioned. We looked at the social networks of these people from the very beginning. Our early studies looked at them. And this slide says, who is in your social network? How many people? This is kind of a la Facebook. And these are the elements: parents, children, siblings, etc., typical. But when we asked who's functional, who it comes to your side when you need help, be it ADL, be it emotional help, the data becomes disturbing. What we find is that parents, not so much children, not so much siblings fall off, relatives fall off, but who's there all the time? The friend. Okay. This is, again, atypical of the social network of a 55 to 60-year-old. Why is this important? As we watch in the news today, the discussions about home health care, AIDS, et cetera, in the health bill realignment, caregivers, who are an important part of care as people age, particularly when there are catastrophic issues like a broken hip, Alzheimer's, et cetera. Those caregivers supply part of the health support to the tune of, the estimates are $400 billion a year annually. This population, from all that we can see and from direct interviews, show that they do not have access to these caregivers. Who will become their caregivers? Many say, well, it'll be the home health care worker. True, but that may be removed from the plate soon. They don't have access to family. They don't have access even to their own churches. So we wonder who will take the place of these caregivers and provide a better quality of life, because, in fact, the dollars probably won't be there. You heard about sex. The lies about getting older is that we don't have sex, we do. It gets better with age, by the way. And I want to mention this work was done in collaboration with Dr. Jeff Parsons at Chest City University and his group. And it was mentioned, I want to make this point here about prevention, that as you get diagnosed, as you age and you get an initial diagnosis of HIV/AIDS, the likelihood of having an AIDS diagnosis increases. Therefore, this population, those diagnosed over the age of 50, are likely highly more infected than, say, a younger cohort. Without going into too much detail, because this data has been published in the book and in press, let me give you an analogy. If a person standing over here is a positive man, and there's a woman standing over here, and we don't know her status, this positive man meets the woman in the bar, okay? And that positive man makes a decision. If he knows the woman is negative, if he knows she's negative by conversation, he will likely use a condom. This positive man, if he knows the woman is positive, 50% of the time will use a condom, 50% will not. Okay, a gray area. If there is no conversation, between the man and the woman, and I use this as an analogy, that conversation does not occur, then in that case, this man will not use a condom. That man will assume, okay, that the person there is positive. Therein lies the risk behavior, and from Dr. Parsons' group, about 16% of this population who are actively engaged in sex are engaged in risky sex behavior. Depression. 2/3 of the people in ROA have moderate to severe depression symptoms as measured by the CESD. Again, in the general population, these measurements by this measure are about 38.6. In ROA, 43.9. This approaches not only moderate but severe depression levels. There is a paper in press right now done again with Jeff's group. And what's important about this paper is it shows that loneliness and stigma can explain half of the depression in this group. This is an enormous kind of provides an opportunity. If we could only reduce the social isolation, and we can, and if we could only begin to chip away at a level of stigma that probably is as great as it was in the 80s, we'd have a large impact on this population. The implications of the ROA study as regards to depression says that 2/3 have severe to moderate depression that's untreated. Let me go back up. And which is kind of amazing given that they're in care. These are people who are in care, who are not getting treated for a condition that is eminently manageable. Depression causes non-adherence to all medications. Okay, it's one of the most common predictors of non-adherence across the board. And we know how critical it is in HIV as it is in any comorbid condition we saw up here. And as I mentioned before, these are people in care but are not getting the right kind of care for depression. We just began a very brief study, and I'll mention it just here now, that using the MacArthur model as an intervention for depression. To get back to the phone, this model is very simple. When a person gets a diagnosis with depression, once a week, a person, not necessarily a professional, picks up the phone and calls and says, "Hi, how you doing? Hello in there," to invoke that song, Bet Midler Sings. It's a very simple, cheap economic intervention. And we have found in our study that it works. And this is creating a social network. And we found that when these folks are put into groups that address depression, not everything, that they tend to create their own social networks, and it fights against all the other comorbidities we see. Lastly, I'm going to mention again prevention. We know that they're not getting a prevention message. We know that there is not age-specific prevention message, except with the help of the New York City Council initiative. ACRIA has been able to collaborate with many others in providing this last slide, prevention materials which really have the faces of older adults on it. Thank you.
Thank you very much. Well, our last panelist for the morning has many distinguished titles and otherwise. However, I've decided to take moderator privilege and to introduce her in my way. I ran into a patient of hers, which we mutually shared a couple of years ago. And I said, well, I'm going to introduce Dr. Aberg at a conference. So how would you introduce her? And she said, well, and I don't want to get it wrong. She said, well, just tell them Dr. A is the best. It's a four-letter word, so I won't use it given that I'm getting videotaped. Is the best blank blank doctor you can ever ask for. She tells me everything. Asks me if I got it, gets me to explain it, and then go on, and then I go on and do whatever I want. Or I should say, she says, and then I go on and do what I do, which is basically what she wants. So with that, I'll leave you with Dr. A.
Another patient that we co-managed together here. But I want to thank the organizers for inviting me today. And